So what we're then going to try and think about, like we say, is it surgical? Start to stabilise the patient, then think about your workup. Don't do it the other way round, because we want to keep tissues alive, we want to keep the patient perfused. Some of them are going to be absolutely definite easies, aren't these, to spot in terms of radiographic or ultrasound appearance. So GDV, mesenteric torsions will show, very rare, but worth recognising on a radiograph because you don't want to go to theatre with them. Pyometra, etc. as well. So we'll go through a few of these, but like I say, we really want to focus on, I may not see a definitive cause, but I've got enough indication to get this patient opened up. So definitive cause, we always use this one for teaching. This is a Weimaraner that swallowed a golf ball. So it's easy to see where its pylorus is because the golf ball is lodged in its pylorus if we're thinking about GDVs. So if anyone wants to, if we've got time, if you want to look at gastropexies this afternoon, we can if we get time as well. This is just here as an illustration. This is the classic textbook presentation. Everyone will tell you a GDV looks like. Pylorus should be at the bottom. If the pylorus is my thumb, it's gone through 180 degrees, so the pylorus is now sat dorsally to the fundus. Important, everyone will tell you, look for pylorus dorsal to the fundus. There's nothing to stop it at 180 degrees. It can keep going. So don't necessarily look for that. This is a 270 degree. It's gone from the bottom, it's gone up to the top, it's gone another 90 degrees, so it's now facing away from us. This is the pylorus cranial to the fundus. So the important thing with the GDV is look for compartmentalization. My stomach is in two sections, my stomach's in two sections. That's what we're looking for. If it's a dilatation, it's just going to be one big circle. We've got compartmentalization, so it's a GDV, even if it doesn't look like the textbook answer tells you it's going to be. Nothing to stop it going 360 degrees and the pylorus ending up back where it should be, but again, it's going to be in a separate compartment as well. 180 degrees most common, but you know, never rule in or rule out on what's most common. Mesenteric torsion, like I say, are very rare, but again, you should be able to get this straight away on a radiograph. If you see, we've got all this fecal density down here, cranial and ventral. This is the colon. So if you imagine mesenteric torsion, everything that's suspended from the mesenteric root has wrapped around itself from there. So our small intestines are all massively dilated and bunched up here. Our colon is pulled down the bottom from here as well. So usually by the time you've opened these up, everything's devitalized between the duodenum and the descending colon, which is usually, if we're trying to see this kind of image and this has been anything longer than half an hour, really the odds are stacked against you in terms of opening these up and actually achieving anything as well. Not always, but it's usually a German Shepherd that's got other digestive issues going on. Exocrine pancreatic insufficiency, etc. Skinny, underweight dog. Is there room for things to spin or move around from there? May mimic a GDV. This patient is going to present acutely painful. You can imagine your whole mesentery twists. Rapidly dilating abdomen, acutely painful with terrible signs of perfusion. They're rare. It's just something on a radiograph it's worth being aware of because, like I say, this is probably something we wouldn't go to surgery unless we knew, you know, it happened very, very recently. Loss of abdominal integrity, we're going to mention, again, this is something that's sometimes glossed over. If we've got loss of abdominal integrity, it's going to be an indication for an XLAP, and this is something that usually easy to pick up on palpation or on diagnostic imaging. So you can imagine this is a cat that's been hit by a car, so we've got a ventral abdominal rupture. You can see the ventral abdominal wall, probably pulled away at the prepubic tendon. So you can see we've got abdominal contents sat subcutaneously. Now some textbooks especially will tell you that, you know, if you've got this kind of rupture of the abdominal wall, you should wait 2 or 3 days for the edges of the muscle to die back so you can see what you're suturing and make certain it's not friable stuff. Now the important thing to remember this is if you look at that radiograph and you can see that, you know, subcutaneously its small intestines are somewhere down around its knees, it's a long, long way from its mesenteric root up here. So if we've got loss of abdominal integrity like that, as soon as the patient's stable, we're going to XLAP it. This is the same cat, this is its jejunum, and you can see we've got a mesenteric avulsion. So this is pulled away for it to be sat that far away subcutaneously from the mesenteric root as well. So with an abdominal rupture like that, as soon as it's stable, we would go to XLAP rather than waiting to see what happens with the muscle edges and things die back from there. Loss of abdominal integrity, this is a severe case. This is a Dachshund, just ate its dinner, went to the park. This is bitten by a Great Dane across its abdomen. No skin punctures whatsoever, but it's ripped all of its abdominal musculature just behind its costal arch. So it's now got a subcutaneous stomach sat here. So you've got loss of abdominal integrity. We can't guarantee what's happening in terms of perfusion of that stomach. We're going to open this up as a matter of urgency. So loss of abdominal integrity is something we're going to be able to spot in terms of imaging, and that's going to indicate that we want to get in there and check all is well.